All right, it's now time to look a little more deeply at the pelvic organs, but as a little bit of a tease, we're going to return to the abdomen briefly and look at the retroperitoneal organs, the organs that are located posterior to the parietal peritoneum, so along the posterior body wall, and foremost among those will be the kidneys. So the retroperitoneum is an area that the organs within it never really have a mesentery. They develop posterior to the peritoneal lining and they never really project into the abdomen in any significant way. So we're going to have the kidneys, the ureters, the suprarenal or adrenal glands, as well as the aorta and inferior vena cava in this area. Now the retroperitoneum is continuous with the pelvic organs, especially as we reflect under the peritoneal lining and get into the rectum, the base of the uterus, the cervix and the vagina, as well as the prostate in the male, and the underside of the bladder. So if we take a slice through the body wall, we see something like this. So right here we have those retroperitoneal organs present, and there's the pancreas. Now the pancreas is a secondarily retroperitoneal organ, as is the spleen. They're close by, but they're not full retroperitoneal organs, as compared to the right and left kidneys, which 100% are retroperitoneal. We've got the aorta and inferior vena cava here. Just always remember that the IVC is just a bit to the right, and the aorta is on the midline mostly, although it's tending to shift a little bit to the left as well. Now, if we're looking at the retroperitoneum and having to access it, it's often done from a posterior approach by splitting the ribs or going inferior to the 12th rib. Since the kidneys are one of the major organs in the area, it's good to know where they're located. The right kidney is a bit inferior compared to the left due to the presence of the liver compressing it and pushing it down. So if we need to access the right kidney, we're going to have the interspace between ribs 11 and 12, as well as the area inferior to rib 12. Whereas the left kidney is going to extend from roughly rib 11, a little bit of the intercostal space between 10 and 11, down below the 12th rib. Now those floating ribs can often be cranked open. You can use a rib spreader to push them away, but one thing that's a little more common these days is to actually get to the kidneys from an anterior approach, but staying just outside of the peritoneal lining. So instead of incising through these areas, below rib 11 on the left and rib 12 on the right, what might be done is that the abdominal oblique muscles will be incised, and the surgeon will then go into the fascia here, the transversalis fascia, and not actually enter the peritoneal cavity more anteriorly. So there's the peritoneum. We want to try to avoid opening it if we can, but sometimes the surgeon can get in and actually get through this transversalis fascia. Now at that point, the fascial planes and the spaces that are present in this area become very important. The transversalis fascia actually splits and surrounds the kidney as the renal fascia, creating a bit of a chamber containing the kidney. Outside of that renal fascia is the paranephric fat, and inside of it is the perinephric fat. The easiest way to keep that straight is remember they go in alphabetical order. So paranephric around the outside, perinephric more closely associated with the kidney capsule itself. Here's the kidney, and notice that the transversalis fascia will remain as somewhat confluent with the other fascias around here, like the thoracolumbar fascia. There's going to be connections there, even if they do form separate layers further laterally. And eventually we get to the psoas fascia here, which is continuous with the transversalis and renal fascia right there. Note that nearby we've got our quadratus lumborum muscle, and then the psoas major and minor are going to be located over here, close by the kidney also. So the kidney itself is covered by a capsule that keeps it separate from the rest of the surrounding environment, largely adipose tissue, and there's actually a space that's not outside the kidney, but that kind of rolls inside. So it's still covered by capsule, but that fat-filled space is called the renal sinus, and it's where the arterial and venous supply to the kidney are coming from. So the renal artery and veins are traveling into its hilum, going through this renal sinus, and coming out of it we have the veins, but also the urinary drainage apparatus. Now, we don't have time to go into the physiology of the kidney. We'll all assume you guys are going to talk about the nephron and urine formation, things like that in other courses, and talk about the pharmacology associated with it. Long story short, we have a cortex on the outside where the glomeruli are. Then we have the medullary pyramids here where the collection apparatus is all come together, and we have the urine released from the medulla at the renal papilla, this little bump here. The urine then goes into a minor calyx, and several minor calyces will fuse to create major calyces. And then the major calyces fuse to create the renal pelvis. Now, this is another instance where I'm incredibly upset that someone had the gall to call this the renal pelvis, and when we have another pelvis somewhere else in the body, when another term would have probably just been fine. But here is where we are. We have the renal pelvis that all the major calyces drain into, and that then produces the thinner, skinnier ureter, which is going to travel down the posterior aspect of the retroperitoneum to get into the bladder. Now, one thing that can happen in these spaces is that you can have infections of the kidney, and sometimes they will be walled off and you'll get little cysts that don't really cause too much trouble. But if purulent material makes it through the renal capsule and gets into the space around it, you can actually wind up with infections and abscesses in the para or perinephric spaces. And the perinephric abscesses are going to be something that can happen when you have a urinary tract infection, where the infection actually erodes through the urinary drainage apparatus, or you can have an abscess in the kidney that releases purulent material into the perinephric space. And that's what we see right here. Here's the normal side over here on the right, and here you can see this swelling of that space surrounding the kidney right there. This might actually cause a visible reddish swelling on the posterior lateral flank of the body, basically the area kind of just under the ribs and to the lateral posterior side. And this is, like any infection, fairly serious, and you want to try to make sure that that gets treated, possibly draining that abscess directly if you need to, and using antibiotics as warranted. Now, another aspect about the ureter as they descend is that they're going to cross anterior to the iliac artery. It's going to travel just anterior to the common or external iliac artery as they enter the pelvis. And the ureter gets multiple blood supplies, and you never want to push it away from its blood supply because these vessels are very tiny. So in the abdomen, you never push the ureter laterally because that will separate it from its blood supply from either the renal artery or the aorta. In the pelvis, however, it's going to get its branches from the internal iliac artery, and you never push it medially away from its blood supply in the pelvis. So just remember that you want to be very delicate with the ureter, because clamping it, cutting it, will definitely damage it, but separating it from its blood supply can be just as problematic in the long term. So here is another illustration basically showing that we've got the ureters traveling down. Their vessels are coming from the renal artery, the aorta, and the common iliac arteries in the abdomen, so we don't want to push it laterally. Then down here in the pelvis, the blood supply is coming from more lateral branches of the internal iliac artery, so you don't want to push it medially. One other key to making sure that you understand which vessels are vessels and which things are ureters is to remember the mnemonic water under the bridge. So the water, aka urine, is traveling down, and we have the gonadal vessels traveling anterior to it, and we have, in the women, the uterine artery traveling superior to it. Now, this mnemonic only goes so far because the ureter does travel over the vaginal artery, and the ureter does travel over the common or external iliac artery up here. But when you're dealing with the ureter, especially during a hysterectomy, it can actually be relatively easy to mistake it for a vessel. It's pulsatile, its coloration is not dissimilar to an artery, so you want to make sure that you've always identified the ureter during any hysterectomy where you're dealing with this area. In the male pelvis, the same basic principle holds except for the whole uterus thing. So here we don't push the ureter laterally in the abdomen, and we don't push it medially in the pelvis. Water under the bridge holds for the testicular artery, but that's about it. Now, much like we don't want bile backfilling into the biliary tree and moving back into the liver, we don't want urine in the bladder to flow backwards up the ureter into the kidneys. That's going to cause some severe problems that we'll deal with in the imaging lecture a bit later. So to keep urine from retrograde flowing, the ureter itself is very muscular, and it's going to peristalse and push urine into the bladder. And as urine fills the bladder, it actually pushes down on this flap. Because the ureter enters in an oblique manner, this flap gets pushed down by the pressure of urine in the bladder and actually seals off the ureter. Fortunately, the ureter is strong enough it can peristalse and quickly spurt, boom, some urine through before that flap closes one more time and prevents retrograde flow of urine up the bladder, from the bladder to the ureter and then to the kidney. And in the instance where there's a uterine or ureteric malformation that allows that to happen, you can have some pretty severe problems with kidneys early on in life. So just to drive that home, the proximal ureter close to the kidney looks a bit like this. We have some transitional kind of scalloped shaped epithelial cells lining the ureter right there. Got some submucosal tissue here, and here's the muscularis externa right there. And as we get closer to the bladder, that whole thing becomes muscularis externa to really propel urine into the bladder even against resistance. One problem that can occur in this is that we can have crystals form in the urinary drainage apparatus, much like we can have crystals and stones form in the gallbladder and the biliary drainage apparatus. In this case, we have renal calculi or kidney stones that form from crystals inside this area, and they can enlarge as the stones get bigger. These stones can be asymptomatic, but if they block an area of the urinary drainage apparatus, that's going to cause problems as urine builds up proximal to that site of blockage. Now, the most common sites of blockage are going to be where we have significant narrowings of the urinary drainage apparatus. So as we go from renal pelvis into the ureter, that's the first site where the caliculi tend to lodge. And then as they pass into the pelvis, they have to cross over the brim of the pelvis, and that's where the external iliac artery and vein are. And that road bump, that kind of hump that they have to get over, is enough of a barrier that it prevents a lot of them from traveling through the ureter at that point, and takes a while for them to transverse it. The third point, not surprisingly, is they have to pierce the muscular wall of the bladder and actually get through that narrow opening as the ureter reaches the urinary bladder. And that tends to be the places where kidney stones tend to get hung up. Now, another thing that can happen is you can have what's called a staghorn colliculus here, where it's basically filling this entire space. And urine might be able to dribble out around it, but it's eventually going to really significantly impede the flow of urine out of the kidney. We can see some plain films here of isolated kidney stones, as well as the staghorn colliculus here. Now, plain films can be used, as can pyelograms, where you take contrast media and actually put it up into the ureter to fill into the calyces, the renal pelvis, and so forth. But these days, the most common way to diagnose them is to use a KUB, which is a kidney, ureter, and bladder CT scan. And that's done without contrast. So since a CT scan is much like an X-ray, we can have nice, well-defined kidney stones present and visible inside the urinary drainage apparatus. And since there's no contrast to wash them out, we can spot them pretty readily. So here's an example of a KUB, and here are the kidneys, here and here, and we got the bone showing up nice and white, but we also have a nice white signal here coming from a stone lodged in the ureter, and we can see it here as well. If we had contrast media that got filtered into the urine, we wouldn't see that at all, and that's actually what's being shown here. We have the same person with an asymptomatic stone present here, but as soon as we put the contrast media in, it's impossible to make out that stone distinctly because the contrast is making it harder to spot. And before we leave this side, I want to point out that we have a little bit of calcification happening right here in the aorta. Now, cystoscopy is another option, particularly if you want to take a biopsy. Now, if someone has a kidney stone, it's commonly associated with extreme pain, and if you look at that spiky little guy, that's probably not too surprising. So that little spiky stone is transversing the ureter and scraping the epithelium all the way down, causing referred visceral pain, as well as some significant actual pain when it crosses some of the nerves and inflames them on the posterior body wall. But in addition to pain, you might also have blood in the urine. And blood in the urine is something you definitely want to follow up pretty rigorously with a patient, because not only could you have kidney stones be responsible, but you can have cancer of the kidney or the ureter. And this is another reason a cystoscopy might be called for. Could be a stone, or it could be a tumor that is bleeding into the urinary space, and you want to make sure that that does not get missed. And once again, here's another little interesting tidbit, is that if we've got asymptomatic stones, they're asymptomatic. They're probably not causing much trouble. That's on the right. But over here on the left, that kidney looks wrong. And it looks wrong because its drainage apparatus is just ballooned out like crazy. And here we can see a little further inferiorly why. There's a big stone lodged into the ureter, and that's causing the urine to back up proximal to it, causing the swelling of the renal pelvis and the calyces, and that is known as hydronephrosis, or water on the kidney. And there's various gradations of that we'll check out a little bit later in the course. Now let's talk about the bladder itself. The bladder is located very anterior in the pelvis. The ureters are approaching it from its posterior lateral aspect. Right here we can see the muscle of the bladder itself is called the detrusor muscle, and it is smooth muscle. We are not in control of the contraction of our bladder. It responds to stretch, and when it's overstretched, it will contract and it will try to squeeze itself all the way down to nothing and completely expel the urine that's inside of it. Fortunately, our external urinary sphincter should be able to help us out. That external urethral sphincter, that's part of the deep transverse perineal muscle. Pubic symphysis is just anterior. There's typically no space between the bladder and the posterior aspect of the pubic bones. But if you have fluid, fracture, bleeding, other things in this area, you can actually see this retropubic space develop occasionally, and that's never a good sign. You don't want to see space between your pubic bones and your bladder. There are some little connections between the pubic bones and the base of the bladder, and that's going to be known as the puboprostatic or the pubovesical ligaments in males or females respectively, and they just help anchor the base in place. They're not strong ligaments like we see in the musculoskeletal system, but rather kind of filmy, membranous sheets of connective tissue spreading from the pubic bone back to the base of the bladder. So let's look inside the bladder itself. Here we have a coronal section viewed anteriorly. So we're looking at the posterior wall of the urinary bladder. And right here, I want you to notice that we have the peritoneal lining covering it. The pelvic organs sit in this space inferior to the peritoneum, but parts of them do bulge out and get covered directly by the parietal peritoneum. Then on the posterior lateral side, we have the right and left ureteric orifices, and that's where the right and left ureter are going to empty into the bladder. There's a smooth crest connecting the two called the interureteric crest, and this triangular area formed by the interureteric crest, the left and right ureteric orifices, and the internal opening of the urethra is known as the trigone of the bladder. It's a very smooth area as compared to the ruffled appearance that we have throughout the rest of the urinary bladder. Now, once we get into the urethra, it's named for what it's transversing. And in women, the urethra is relatively short, and it's going to pass through the urethral sphincter muscle here, then through the perineal membrane, out into the vestibule. And this is called the membranous urethra, and it's just passing through all those spaces. We have those skenes or urethral glands emptying in there, and once it's in the vestibule, it's out of the body. In males, we have basically the same starting point with ureteric orifices, interureteric crest, trigone of the bladder, etc., but the ureter has a much longer course, and this is one reason why men tend to be less prone to significant urinary tract infections, is because infections have to travel much further up the male urethra to get into the bladder, and then hopefully, or not hopefully, but then eventually to the ureters or the kidneys. Now the prostate is wrapping around the urethra, and we're going to have the prostatic urethra present right there. There's a bump on its posterior side called the prostatic utricle, and that is where the ductus deferens is going to empty spermatozoa, and the seminal vesicles are going to empty their secretions into the urethra. We'll see more on those in a little bit, but just know that the ductus deferens and the seminal vesicles are releasing their products into the prostatic urethra at the prostatic utricle. From there, the prostatic urethra gives way to the membranous urethra, which is crossing through the sphincter urethrae muscle here, and then it enters the corpus spongiosum and becomes the spongy urethra. And that spongy urethra continues all the way from the bulb of the vestibule to the opening at the tip of the glands of the penis. That's called the meatus, or the external urethral meatus, is where urine leaves the body in males. Now, jumping back up to the kidneys, we're going to talk about the suprarenal glands very briefly and just their anatomy, their location. These glands form separate from the kidneys, and you can have agenesis of a kidney, no kidney at all on one side, and the suprarenal gland will be sitting up here happy as can be, just without a kidney nearby. They are located on the superior pole of the kidney, and they get their blood supply from a few different areas. We're going to have the blood supply coming from the inferior phrenic artery and the aorta and the nearby renal artery. So multiple arteries supplying the suprarenal gland, also known as the adrenal gland, but each adrenal gland has a single vein draining its products, and that's going to be the left suprarenal vein going to the left renal vein, or the right suprarenal vein draining to the vena cava right here, the inferior vena cava just nearby. So the adrenal gland is a massively important endocrine structure. It's going to release many kinds of hormones, and it has two embryonic origins and therefore two entirely separate types of products. It has a capsule on the outside to protect it. It has an outer cortex and an inner medulla. Now the capsule just keeps it safe, separates it from other structures, and keeps it distinct. The cortex is going to release a variety of hormones, the mineralocorticoids, the glucocorticoids, and the gonadocorticoids, or as it was shortened when I was in grad school, salt, sugar, sex. The medulla is where, when we called it the adrenal gland, it got its name. This is where adrenaline, which is now not considered to be a single thing, but a mixture of epinephrine and norepinephrine, can be released by the adrenal gland or the suprarenal gland, and the cells inside here are called chromaffin cells, and those are the ones that release their products directly into the bloodstream, so that when we have a sympathetic response, that adrenaline, that epinephrine and norepinephrine, floods our organs, frees up sugar, constricts some blood vessels, opens others wide up, and lets us react to the problem at hand. From a side view of the female peritoneum and pelvic cavity here, we can see the pubic symphysis anteriorly, and just posterior to that we've got the urinary bladder. There's not usually this much space between the pubic symphysis and the bladder, so just be aware that that's usually a potential space. And the urethra stretching down. We've got the uterus right there, the fundus poking up, the body coming down here leading to the vagina, and then the rectum here leading to the anus. I want you to note that the peritoneum covers the top of the bladder, some of the body and fundus of the uterus, and then the rectum is partially covered by peritoneum, and then we wind up transitioning completely below the peritoneal line there. The bladder, when it's distended, can actually stick up pretty far and be covered by peritoneum there. These folds create different pouches or spaces inside the peritoneal cavity, the vesicouterine here between the uterus and the urinary bladder, and the rectouterine between the rectum and the uterus. These are important because fluid is going to tend to fall into those spaces when there's a lot of fluid in the peritoneal cavity, and so when someone's seated or standing upright, it's going to go to the lowest space, which is the rectouterine pouch, also known as the pouch of Douglas. And if you need to sample that fluid, and sorry for making anyone cringe in advance, you can actually advance a needle through the posterior wall of the vagina near the cervix and into this space to do a colposcopy, to pull some of that fluid out for examination. So here's a view of the same organs, but from above we're going to be looking at the peritoneal lining of the pelvic contents. So right there's the bladder, and we have a median umbilical fold stretching off its midline and going right up on the posterior side in the vicinity of the linea alba right there. So we've got the median umbilical fold. It's a remnant of a structure called the urachus, which we'll talk about in development. Just beside it we have the medial umbilical fold, which is the covering over the obliterated umbilical artery. And laterally, we have the lateral umbilical fold, which is the covering over the inferior epigastric artery and vein. And these are important landmarks when we're doing scopes or other sort of as minimally invasive surgeries. If you need to find the bladder, you locate the median umbilical fold and trace it down. If you need to find the internal iliac artery and vein, you follow the medial umbilical fold further into the pelvis. And if you need to find the external iliac artery or vein, or the vas deferens, you're going to then follow the lateral umbilical fold to its origin. So here we can see the rectum, the bladder, and between them we have the uterus. Now the uterus is associated with the fallopian tube and the ovaries. And I want you to note that the ovaries are on the posterior side of the uterus. Now these are all covered by peritoneum, including the ovaries, including the oviducts, and this ligament right here called the round ligament of the uterus, all covered by peritoneum. There's the fundus, which is the part that pokes up, and then the uterine body, the majority of the uterus, leading to the cervix, which is where the uterus is anchored by ligaments just deep to the peritoneal lining. We've got those folds creating pouches, like the rectouterine pouch, pouch of Douglas, or the vesicouterine pouch more anteriorly. The same basic principle holds true in the male, we just don't have a uterus to account for. So there's the bladder and the median umbilical fold. Medial umbilical fold right there, and inferior epigastric vessels covered by peritoneum, making the lateral umbilical fold. Same basic ideas. We've got the rectum, and between the bladder and the rectum, we're going to have the ductus deferens coming in, meeting up with the seminal vesicles, and they're going to pierce the prostate, which we can't quite see here because it's at the base of the bladder. And that's going to allow the fluid from the seminal vesicles and the spermatozoa from the ductus deferens to get to the prostatic urethra. Also note we've got the ureter coming in here. We can visualize it traveling inferior to the ductus deferens to get to the posterior side of the bladder. And in males we have a rectovesical pouch, not anything else, because there's only two organs to create that space. We have some folds, like the vesicosacral fold, that help anchor the prostate to the sacrum, and that makes some little ravines on either side of the rectum called the perirectal fossae, one on the right and on the left. So as we trace the flow of purulent fluid through the abdomen, it makes a difference whether we're seated, standing, or laying down. If we're laying down, the fluid will wash into a variety of other areas, and if we're seated or standing, it'll go to the lowest area. So in women, that's going to be the rectouterine pouch, and we can see it traveling. If it's near the liver, in this parahepatic space, it's going to travel down just to the lateral side of the ascending colon. Here, if it's traveling from this area near the intestines, it's shut off by the mesentery of the transverse colon and the root of the mesentery of the small intestines here, but it'll travel down this way. And if the fluid is on the left side, it's going to be kind of locked out from going much higher because the spleen has a peritoneal connection to the transverse colon. It stops fluid from going much higher, but fluid on this side, the descending colon, will move laterally down to get to the rectouterine space that way. If we travel the other way, though, somebody has fluid in their abdomen and they lay back, it's not going to go very far up on the left. It can't go very far up in the midline because the mesenteries are keeping it locked in place, but on the right it can actually travel a fairly significant distance up around the liver and even into the omental bursa, that lesser sac, by traveling just posterior to the hepatoduodenal ligament and the porta hepatis there. So fluid in the right pericolic gutter really does have a free shot to go higher up and cause inflammation and problems elsewhere. And there we go. If we have fluid inside that omental bursa, say we have a ruptured posterior wall of the stomach, we have something that's eroded it, we can actually have the fluid leave through that space, enter this parahepatic area, and then it can wind up going down the right pericolic gutter to get into the rectouterine pouch there. Now, regarding the uterus itself, it can be situated in a few different ways. In blue is showing more or less the typical version. Blue and green are fairly typical, but you can have the uterus anteverted, meaning kind of just tilted forward on its base, or retroverted. Retroversion is going to be kind of hanging back this way. But note that the uterus maintains a consistent shape. That's to be distinguished from retroflexion or anteflexion, where there's an actual bend or kink in the uterus, anteflexion going forward and retroflexion going posteriorly. So let's talk about the uterus and the associated structures. That's called the adnexa, and you're going to hear that term a lot. The adnexa are basically all the things that are associated with the uterus. We've got the peritoneal lining here broadly rolling across it. We've got the ovaries and the fallopian tubes or oviduct. So the oviduct or fallopian tube is going to be here. It ends with this kind of flared out horn that's near, or bell rather I should call it, this flared out bell near the ovary. The ovary's there. It's going to be connected to the posterior body wall by what's called the suspensory ligament of the ovary. And that's basically just the peritoneal covering of the ovarian artery and vein. It's really not a ligament in the true sense, but it's called suspensory. It doesn't make much sense in people, but in animals, especially quadrupeds, where their ovaries are hanging down, this ligament actually does suspend the ovary a bit from the posterior body wall. So the suspensory ligament for the ovary, the important thing to remember about it is that it contains the ovarian artery and vein, and you need to account for it during an oophorectomy or an adnexotomy where you're taking all the adnexa out. The ovarian ligament connects the ovary to the uterus, and it's continuous with, at least early on, the round ligament of the uterus right here. So this used to be one continuous stretch until the uterus was able to anchor that structure and prevent the ovary from descending towards the labia majora. And in men, where there's no uterus, that connection pulled the testes all the way down into the scrotum. So the broad ligament is the name we give to the sheet of peritoneum that covers all these structures. So it's the broad ligament. It really does fan out over everything here, and we can subdivide it into the part that connects directly to the uterus. That's called the mesometrium. The part that connects to the ovary itself is very small. It's just a little slip right back here, but it is present. That's going to be the mesovarium. And the part that connects the fallopian tube or oviduct to the rest is called the mesosalpinx. So just know the difference between a mesosalpinx, a mesovarium, and a mesometrium, and they're all parts of the broad ligament. So we'll now take a slightly different view of the adnexa in the uterus. So there's the ovary. It's connected to the uterus by that ovarian ligament, and it does not have a direct connection to the oviduct, although they're very close by. That leads to the uterus. We've got the fundus of the uterus, the dome that's sticking upward, and the rest of it is called the body of the uterus. And even though we're only pointing to one spot, the body of the uterus is the whole thing. We've got the cervix here, this thickened area at the base of the uterus, and it has an internal hole, that's the internal os, and an external hole, the external os of the cervix. So just be aware the cervix is the whole thing, and the os is going to be the opening on the inside, internal, or outside, external. Now the wall of the vagina does not go straight to the external os of the cervix. It kind of folds up and then connects a little bit further superiorly so that the external os and a bit of the cervix actually protrude into the vaginal ceiling. Because of that, there's a corner here where the vagina meets the cervix, and that's called the fornix. Now the fornices are basically circular because the cervix is mostly circular, but people will often talk about the lateral fornix, the posterior fornix, the anterior fornix. They're just referring to the anterior, posterior, or lateral right and left sides of that meeting place between the vaginal wall and the cervix. All right. So let's take a quick look at the ovaries, and we're not going to be able to go into everything about how they develop and the hormonal signals that are responsible and how oocytes mature. That's an entire lecture, if not an entire course of its own. But right here, we have lots of primordial follicles. These are little oocytes that have not developed. Women are born with a huge number of these primary follicles in an inactive state, and once adolescence hits and women reach sexual maturity, these will start developing each menstrual cycle into primary follicles, which will become mature or Graafian follicles, and each month one ovary will shed one egg. The ovaries kind of take turns under normal circumstances, and once the egg is released, it could possibly be fertilized if it makes its way into the oviduct, and we have a ruptured follicle there that's going to become what's known as the corpus luteum. Corpus luteum still releases hormones that helps maintain the uterine lining so that egg has someplace to implant if it does indeed get fertilized. And as the cycle continues, fertilization doesn't occur, the corpus luteum will dwindle and go away, becoming a little white scarred area called the corpus albicans, which will then dwindle away to pretty much nothing with enough time. So now let's return to this same picture and take a look at the oviduct itself. So an egg, or an oocyte that's shed, is going to try to migrate into this area. And the fimbria, or the little fingers, this area, the little fingers are sticking off here, and they actually move around the surface of the oocyte. They're actually trying to position themselves near a follicle that's about to rupture so that it can move into the oviduct relatively easily. So the fimbria is this the part that's most closely connected with the ovary. That leads to this wider area, the infundibulum, then the ampulla, the isthmus, and then the part that's going to transverse the uterus itself, the uterine portion, and then we get to the actual uterus. The internal lining is the endometrium, and typically fertilization happens in this area, but implantation happens in the uterus, and it's a problem if that happens differently. So here we can have the endometrium developing the spiral arteries and the glandular secretions that are going to allow implantation to occur if there's a fertilized egg present, and the myometrium will expand to allow the fetus and embryo to develop and eventually contract to help expel the fetus at the end of gestation. Now right here, there's a little remnant of the male ductwork back from when we were indifferent, and I only draw attention to it because they've illustrated it so nicely here, and it's one of my favorite anatomy terms. This is the epuphoron. So just, if anyone needs to come up with a good password for a online banking account, may I humbly submit epuphoron for your consideration. So problems that can occur in this process are if the eggs are fertilized outside of the oviduct or the uterus, and this can result in what's called an ectopic pregnancy. That fertilized egg will implant in the perineum and start developing, and it's going to try to draw blood into the area, but the perineal lining is not set up to handle that amount of blood flow to support a developing embryo, and ectopic pregnancies can and will kill people if they're left untreated, and generally are removed. Another problem can occur if we have implantation in the oviduct itself. We have a tubal pregnancy. Now those are basically going to have the same sort of problem, but in the tube. They're going to have a fetus implant and start developing, but the blood vessels and the lining of the oviduct are just not equipped to handle growth of an embryo up into the fetal stage, and generally it's going to be fatal for both the embryo and potentially for the mother. Now right here, if we take a look at deeper structures, we've removed the broad ligament and indeed all the peritoneal lining. So we've got a view of the deeper pelvic organs in the female. There's the bladder. We can actually see those folds of the detrusor muscle present right there. The ureter's coming in just posterior to it. Water under the bridge. So we've got the uterine artery traveling just superior to it there. We've got the cervix right here. Uterine vessels coming to it. And there's that recto-uterine pouch of Douglas right behind the uterus and just anterior to the rectum. Now, the cervix is anchored in place by some very strong but kind of sheet-like ligaments deep to the peritoneum. There's the pubocervical ligament, which basically helps anchor the cervix anteriorly to the pubic bone. We've got the sacrocervical ligament right here, making some of the boundaries of that recto-uterine space. And then the largest one, and the one that contains the actual vessels going to the uterus and the vagina, is the transverse cervical ligament, also known as the cardinal ligament. Here's another view. It's pretty abstract, but it gets the idea across, is that we've got the cervix suspended by these tough ligaments that are helping keep it in place and preventing prolapse of the uterus through the pelvic area here. So we've got the pubocervical, sacrocervical, and transverse cervical ligaments here. And just remember, you're going to hear the transverse cervical ligament called the cardinal ligament very frequently. So same idea. Let's take a look here. We've got the ovarian vessels coming down. Water is under the bridge. So there's the ureter posterior to the ovarian vessels. we've got this artery here. Now, normally in class, I'd bug you to tell me what it is, but I can't do that right now. So take a moment. What do you think? Obturator is correct. How about this one? Umbilical, not quite correct, because umbilical is the parent artery here, and it's dwindled away to become this little atrophied cord right here. This is the branch of the umbilical going to the bladder. So it's the superior vesical artery right there. We've got the uterine artery nice and clear going into the uterus from the side, and coming off of it the vaginal artery diving a bit deeper. And the uterine artery travels over or superior to the ureter. So there's water under the bridge, but that does not hold true for the vaginal artery. So they kind of straddle the ureter on the way to the uterus and the vagina. Now this illustration is a little excessive, but it drives home the idea that you've got a massive amount of anastomotic blood flow going to the uterus. So here's the uterine artery traveling just superior to the ureter right here, and it just forms this network that fans out across the lateral side of the uterus and then into this network of vessels on the anterior and posterior sides. Off of the uterine artery we have our vaginal artery feeding into that channel as well, and our internal iliac is going to give off some branches in the perineal region that are going to this area of the perineum, as well as this area just below the perineal membrane there. Now I want to also draw attention to the fact that the fallopian tube, or the oviduct, gets its blood supply from the uterine artery, but also some anastomosis here with the ovarian artery. So the uterine and ovarian vessels do anastomose together, and the fallopian tube or oviduct shares their blood supply. So we're now going to revisit the male internal organs, and we've actually covered a lot of this ground before, so let's just review that we have the ureteric orifices at the posterior lateral side of the urinary bladder. We have the prostate sitting at the base of the bladder there, and the prostatic urethra traveling through it, and the prostatic utricle marking where the ejaculatory ducts that are carrying the secretions from both the ductus deferens and the seminiferous tubules will be entering. We have a thin layer of muscle, but a very important one, the sphincter urethrae, portion of the deep transverse perineal muscle is there, and the portion of the urethra that transverses that is called the membranous urethra. Then we get to the spongy urethra within the corpus spongiosum. Let's do a quick view of the same stuff from a sagittal plane, and once again, ureteric orifices there. Now we've got that prostate, very visible, prostatic urethra traveling through it, and there's once again the membranous urethra transversing the sphincter urethrae muscle, leading to the corpus spongiosum and the spongy urethra within it. There are multiple little glands emptying into here, the glands of Littré, in addition to the larger bulbourethral gland a little more proximally. Note here that we've got the seminal vesicles. Ductus deferens aren't quite visible here, but the seminal vesicles and ductus deferens are going to drain into a single ejaculatory duct, which reaches the prostatic utricle right there. Let's take a view from the posterior side, and now we can see that the ureter and ductus deferens are running very close to each other. The ductus deferens is just running superior to it as it enters the bladder, piercing that smooth muscle of the bladder itself, the detrusor. And then the ductus deferens, or vas deferens, will balloon out a little bit into its ampulla. And the base of the ampulla meets the seminal vesicle, which is secreting fluid right here, largely, I believe, fructose-rich fluid to get the sperm mobile, but my physiology is a little rusty, so if you hear something contradictory to that, go with what your other instructor says. And these two will join into a single ejaculatory duct. It is going to travel on the right and left through the prostate to get to the urethra. And once again, those little bulbourethral glands just hanging out nearby. If we look at a cross-section of the prostate, most of the prostate is going to be secreting fluid that is going to enter the prostatic urethra through these multiple ducts right there. So these prostatic glands are secreting into these ducts to increase the volume of the seminal fluid. We have the ejaculatory ducts traveling from the ductus deferens and seminal vesicles to travel in this way. And I want you to note here that we have a capsule of the prostate, and this capsule is absolutely permeated with arteries, veins, and there's even a huge sheet of nerves traveling across the outer surface of the prostate, which is one reason prostatic surgery tends to be such a nightmare, because it's a very vascular organ with a lot of nerves nearby that have a lot of impact on both sexual function, urinary continence, rectal continence, and so forth. And here's just an artistic view of that rich blood supply to the prostate. And it's also showing one of the major problems with the prostate, apart from prostate cancer. As men age, they tend to actually have BPH, benign prostatic hypertrophy. Benign does definitely not mean good, because this ballooning of the prostate can actually shut, not completely usually, but it can make it difficult for urine to leave the bladder, hence the reason a lot of older men have to go to the restroom multiple times in an evening. So here we can see an illustration of the prostate is enlarged, and we have a little flap here that's making it difficult for the urine to drain, causing obstruction and therefore expansion of the bladder as a result. This illustration is also a very good place to point out that when the prostate is enlarged or prostatic tumors might be suspected, the digital prostate exam is quick, easy, efficient, and I wouldn't characterize it as pleasant, but you can see right here the proximity of the rectum's anterior wall to the prostate itself at the base of the bladder makes this exam something that's absolutely essential in any kind of primary care or other setting where you might have to suspect prostate cancer as a possible problem that your patient would come in with. So being able to palpate the prostate for hardened nodular areas, expansion overall, or uneven expansion is going to be a very important skill to develop. All right, that's the end. Kind of. We haven't finished talking about the rectum yet. Yep, let's do it. So we're going to revisit the rectum quickly, which we already covered in the abdominal portion of the course, but since it extends into the pelvis, it's good to refresh our memory of those structures and the context here. So note, now we can make sense of the other structures in the area, like we have the obturator internus here forming the wall of the pelvis. We have the pudendal canal with the internal pudendal artery and vein, pudendal nerve there, just rolling along inside the fascia of that muscle. And nearby we have the levator ani, and separating the two is the ischianal fossa full of adipose tissue. So the levator ani now we can actually see doing what we expect it to do, obliquely descending medially to get to the rectum, and as you can see, if this contracts it will indeed elevate the anus, hence the name. We've got the sigmoid colon turning into the rectum. We once again have transverse rectal folds present there to help move the fecal material along. The smooth muscle of the rectum has an inner circular layer which thickens at its base to become the internal anal sphincter, and it's continuous with, but not completely like the external anal sphincter, because that is skeletal muscle innervated by branches of the pudendal nerve. The inferior rectal nerve is traveling there. We have the anus itself, once again with the anal columns and the pectinate line separating it there, the anocutaneous line. And, yep, same exact slide that we saw before. Just refresh yourself on the fact that we have those three transverse rectal folds moving the fecal material down to the anus. We have the anal columns present there, and the actual distinction of where the anus stops is up for debate depending on which specialty a person is coming from. So I will not ask you to choose between here or here as the stop or start of the anus. Just know that there are feuding definitions for exactly where the anus stops and the rectum begins, and vice versa. The anocutaneous line marks where the anus moved in from the outside and met the gut tube coming from within. Blowing up the picture here a little bit, we can see the continuity of the circular smooth muscle and the internal anal sphincter, also smooth muscle. We can see the levator ani, skeletal muscle, coming in to form the external anal sphincter, which has multiple parts, and I will be completely honest, these are very difficult to distinguish in a gross anatomical dissection, but interestingly, the differences can be palpated. Particularly at the anocutaneous line, there is a divot where the internal and external anal sphincters meet that can be palpated and appreciated in a clinical setting, but not in an anatomical laboratory. Don't forget that we have the anal valves present here in between each anal sinus and in between each anal column, and the space there forming the anal sinus is an area where we can get purulent material, fecal material impacted or stuck, and that can cause inflammation resulting in anal fistulas. Internal rectal venous plexus, the veins here are going to be draining to either the superior rectal vein, which is going to be a vein that winds up going to the portal hepatic venous system, and we also have middle and inferior rectal veins going to the internal iliac veins. So this is an area where we have one of those portal caval anastomoses, a spot where portal hypertension can manifest by causing expansion of these into internal hemorrhoids. And on the outside, we have the external rectal venous plexus, which primarily drains to either the inferior or middle rectal veins. These can occasionally become involved if there's significant portal hypertension, but external hemorrhoids, inflammation of these vessels, is a little bit more common due to trauma, irritation, or inflammation of the anal area. Now, this incredibly busy picture is actually really nice in one regard, and it's that it shows all the arteries going to the rectum throughout its course. We have the inferior mesenteric artery giving off a branch to the descending colon, that's the left colic artery, multiple sigmoid branches, and then its final branch, the superior rectal artery, going into the rectum here within the pelvis. Then we also have the internal iliac artery here and here, giving off the middle rectal artery superior to the pelvic diaphragm, and off of the internal pudendal artery we have our inferior rectal artery going to the anal area and the external anal sphincter. So just be aware the rectum and anus have three separate blood supplies, although they are interrelated. Inferior and middle are going to be coming from the internal iliac artery, whereas we have to go all the way back up into the abdomen to get to the parent of the superior rectal artery. And then the veins. We talked about this very briefly with the internal and external venous plexi, but we can see here a lot more clearly that external anal or rectal venous plexus is going to feed into the inferior rectal vein, a little bit of connection with the middle rectal vein here, and then these internal plexi are going to be draining to the middle rectal veins, but also the superior rectal vein has some drainage happening here. And the main thing to appreciate once again is that if we have portal hypertension or blood building up, backing up within the portal system, it's going to back up into the superior rectal vein, cause all of these to balloon out, and possibly enlarge these internal hemorrhoids to the point where they can actually become pendulous and dangle from the rectum. All right, that's it for this lecture. I'll see you guys back in a moment when we talk about the lymphatics and the nerves.